So hello everyone, I hope I'm audible and visible. Can I all get a quick thumbs up from all of you if my audio video is fine? So welcome all of you. I'm Dr. Chesta Aggarwal, your NEET PG educator on the best online platform, that is Unacademy. Now on Unacademy we have a feature which is known as Compete. Here we have okay, yeah. So welcome. I think you all can see me and hear me. My audio video is fine. Now we have a feature which is known as Battle, where you can compete with the peer on the live Android app. So the app will automatically search for one of the student and you will be given a direct target. Now we have a NEET PG 2023 batch. I would be requesting all of you to kindly be a part of it. Then we have a NEET PG perfect batch where you have 4 month with 1 month extension. Using a code Chesta10 will give you Chesta10 code will give you a 10% discount on any of these subscriptions. So I would be requesting all of you to kindly go through this and be a part of Unacademy. Now let us start with the first question of the today's session. I hope all of you is ready for the first question. Please tell me the answer. A 40-year-old man with intermittent upper abdominal pain for 4 months. There is episodic hot flushes which involves the face, upper chest for 2 months, watery stool 5 to 6 episodes per month. He had a dry cough for 8 days and he had no comorbid illness. The investigation shows increase 5-hydroxyindole acetic acid and the cutaneous lesion as seen in the image. What can be the diagnosis for this particular condition? So very nice, Arun, Yogit, Akshata, positive vibe, Abhishek. It's a very classical image showing niacin deficiency, that is vitamin B3. Now here patient develops photodermatitis. So what are parts which are covered, they do not develop the lesion, but the part which are exposed develops a very classical lesion. Okay, so that is about pellagra. Now in pellagra, other than involvement of skin, you develop what is known as diarrhea, you develop dementia, and if patient is not taken care, if the niacin is not supplement, it can even give rise to death. So these are some of the features related to vitamin B3 deficiency, which is known as pellagra. Vitamin B3 deficiency known as pellagra. Clear? So very nice, Aishwarya, Muthu, Arun, Yogit. The correct answer of this question is option number 3. Next. Child with oral lesions, circumoral vascularization. What is the correct answer? Very nice, great. Anybody else want to answer this? Avinash, Abhishek, Nick, positive vibe, Vakshata, Muthu. Now if you look at the image, there is glossitis and you can see some redness. The tongue, yes, there is loss of papilla. That is why I said that you have glossitis. This is a feature of riboflavin deficiency, which is vitamin B12, which is vitamin B2 deficiency. In riboflavin, the tongue, the lips, the angle of the mouth, they are all chapped. In these individuals, seborrheic dermatitis-like features can also be seen. In them, seborrheic dermatitis-like lesions can also be seen. Next question. Now first let me show you the image. I think little bit is hidden behind me. Look at this. You can see that there is perifollicular hemorrhage and there is bleeding from the teeth. Gum bleeding and perifollicular hemorrhage, these are the two features given. Now think of the answer. Very nice, Muttu, Yogit, Aishwarya, Nick. Aliza, positive vibe. Very well done all of you. Adil, Shehbaz, Akshata. Great. Now we have a 6-year-old child with irritability since 15 days. He refuses to walk and seems to have tenderness in both the leg. He has petechiae, mucous membrane is bleeding and healing is improper. X-ray shows atrophy of the epiphyses. What is the sign called as? This is Wimberger ring sign. Very classical of scurvy. Wimberger ring sign of scurvy. Next. Psoriatic patient on topical treatment sustained sunburns. 1 month later, he developed a flare-up of psoriasis. Soon after starting the prescribed drug for psoriasis, he manifested erythema and burning of his left cheek and left forearm. What is the most likely drug to produce this manifestation? What is the most likely drug to produce this manifestation? Very nice. So what exactly is happening here? This is a radiation recall. The reappearance of the radiation-like features, radiation recall phenomena. It's a feature of methotrexate. Radiation recall is a feature of methotrexate. Next. What is the answer? Infant present with severe itching, irritability, generalized erythematous papule, pustules on palm and sole. Hint here is intense nocturnal itching and family history positivity. Very nice. Both of them indicate that we are dealing with a patient of scabies. It is an infection with Sarcoptes scabies. It's an infection with Sarcoptes scabies, which is a parasite, and it classically affects the web spaces, wrist, axilla, groin, periumbilical region. How to treat? Anyone? What would be your treatment option? How to treat? Can anybody tell me how to treat them? Yes, you give 5% permethrin. 5% permethrin is the drug of choice. It works on sodium channels, causes paralysis in the mite. Works on the sodium channel, causes paralysis in the mite. Next. What is the answer? Next. Answer to the next question. Anyone? A 65-year-old man with asymptomatic erythematous swelling on the right ear, which has been gradually progressing for 15 years now. On examination, we see some infiltration on the earlobe, and there is atrophic cicatricial scarring. So this is something very important. Now I want all of you to look at the image. In this patient you can see that there is a plaque on the ear with a very classical atrophy, and there is PPD which is positive. Can you think of something when the PPD is positive and there is presence of atrophy? It is a very classical feature of lupus vulgaris. It's a very classical feature of lupus vulgaris. Clear all of you? Anyone with any confusion? Very classical feature of lupus vulgaris. Next. What is the correct answer of this question? Little long question, but let me see how many of you can answer. Anyone? A 67-year-old woman with 15-year history of painful multiple joint and a symmetrical migration and affection. He did not report any kind of skin lesion, but nail shows, let me mark the important points. Nail shows leukonychia, crumpling, onycholysis and hyperkeratosis in a patient with involvement of joint. Family history was positive, and recently there is a lesion on the skin. So according to Casper's criteria, this becomes a case of psoriatic arthritis. There are two criteria to diagnose the patient of psoriasis. One is mole and writhe. One is mole and writhe criteria. Second is Casper's. Mole and writhe criteria says that there should be presence of arthritis. There can be skin lesions and seronegativity. And Casper's add 3 more to these 3 criteria. According to Casper's, along with these 3, there should be a family history positivity, involvement of nail and involvement of digits. So very important feature of Casper's. Very important features of Casper's criteria. Next. If the image is not visible, let me just show you the image first. Look at the image. Patient present with a large swelling and multiple small tumors with some hyperpigmented patches. Can you tell me what is the diagnosis? A mother who is 50-year-old, several tissue cutaneous nodules on the body. This is a patient of neurofibromatosis type 1. Neurofibromatosis type 1. Neurofibromatosis type 1. The hyperpigmented macules which is present here, it is cafe au lait macule. They are present since birth. True. It is an autosomal dominant condition. True. Slit skin smear is required. Slit lamp examination is required to look for the presence of. Slit lamp examination is required to look for the presence of iris leash nodule. Iris leash nodule. Okay. The only incorrect statement is option number 2. Large masses are seen in this patient are not considered to be diagnostic. That is not correct. Plexiform neurofibromas are diagnostic. Plexiform neurofibromas are diagnostics. Clear? Plexiform neurofibroma, it is diagnostic. This large mass which they are talking about is the plexiform neurofibroma. It is plexiform neurofibroma, and these are diagnostic. So option number 2 becomes wrong. Next, what is the answer of next question? Please tell me the correct answer. Very nice. These are black granules. The color of the granules are black with some blood tinting, and there is swelling of the foot. What can be the diagnosis? What will be the diagnosis? It is eumycetoma, a very classical triad of swelling, sinus discharge, and grains. You see black color grains in the patients of eumycetoma. You see black color grains in the patients of eumycetoma. Next, tell me the answer. What is the correct answer? It's a very lengthy, long question, but it's very easy. Now, let us mark the important points. Let us mark the important points. Patient presented with bullous lesions on the skin. There is a history of oral erosions also. In addition to that, we can see some squamous cell carcinoma history. This is a patient with paraneoplastic pemphigus. Paraneoplastic pemphigus is a type of pemphigus. Paraneoplastic is a type of pemphigus where the pemphigus patient have an underlying malignancy like non-Hodgkin's lymphoma, chronic lymphocytic leukemia, thymoma, or Castleman's disease. Castleman's disease. These are the diseases associated. Non-Hodgkin's lymphoma, CLL, thymoma, and Castleman's disease. Clear? Castleman's disease. The prognosis of this condition is poor. The presentation is variable. They can have features like pemphigus, pemphigoid, even bullous erythema multiforme. They can have any sort of manifestation. They have a very recalcitrant lesions associated with them. Next. What is the correct answer? A male with cryptorchidism, large dirty brown scales, skin biopsy shows hypergranulosis, steroid sulfatase deficiency. What is the probable diagnosis? Great. Now this is an example of X-linked ichthyosis. Let me discuss that a little bit in detail. What is X-linked ichthyosis? Two types of ichthyosis we need to know. One is ichthyosis vulgaris and another is X-linked ichthyosis. Two types of ichthyosis we should know. In ichthyosis vulgaris, It is an autosomal dominant condition, but X-linked is X-linked recessive. The problem here is there is deficiency of filaggrin protein, and here there is deficiency of an enzyme steroid sulfatase. Clinically, in ichthyosis vulgaris, we see yellowish, fine, small sized scale which is present mainly on the flexures, mainly on the extensors with sparing of flexures. In these individuals, you will see associated atopic dermatitis, on doing histopathological examination, you see hypogranulosis. In X-linked, the clinical feature is they have dark, large scales without any spare, present all over the body. There is no sparing. It is associated with cryptorchidism and corneal opacity. And when you do a histopathological examination, you will see very classical hypergranulosis. Very classical hypergranulosis. So that is a complete difference between ichthyosis vulgaris and X-linked. The answer here becomes option number 3. Next, what is the correct answer? Patient with 7 irregular hyperpigmented macule on trunk, multiple small hyperpigmented macule on the axilla, groin. Since early childhood, there were no other skin lesions. Which is the most likely investigation to support? Can you tell me the diagnosis here? Very nice. It's a patient of neurofibromatosis type 1. These irregular macules are cafe au lait macules. These are axillary freckling. And if you do a diagnosis on slit skin smear, on slit lamp examination, you see iris leash nodules. You see iris leash nodules. Clear? Next, what is the answer here? What is the answer of this question? 45-year-old men who presented to dermatology OPD with complaints of excessive thickening of skin of palm and sole. He gave a history of similar features in one of his child. On examination, the nail were dystrophic. Now, this is a question from a topic which is known as ectodermal dysplasias. Now, what are the ectodermal dysplasias? These are those group of disorders where all the ectodermally derived tissues are defective, like hair, like nails, like teeth, like skin, like sweat glands. So this is a group of disorder where all the ectodermally derived tissues are missing. We have divided them into two groups depending upon the involvement of sweat glands. If sweat glands are normal, it is called as Clouston syndrome. If sweat glands are normal, it is known as Clouston syndrome, and if sweat gland is reduced in function number, it is Christ-Simon-Torin syndrome, also known as hypohidrotic or anhidrotic ectodermal dysplasia. This is known as hydrotic ectodermal dysplasia. So that is the difference. One is hydropic and another is non-hydropic ectodermal dysplasias. Clear, all of you? Clear? So answer here is not 1, it should be 2, because there is no hypohidrosis. It means sweat gland is normal, and if it is normal, it should be Clouston syndrome. It should be Clouston syndrome. Next. What is the correct answer? Cell cultures from a patient with this disorder exhibits the low activity of nucleotide excision repair. What is the correct answer? They have clearly mentioned that these patients have multiple skin cancers, premature death, and there is DNA repair defect. The correct answer is, this is a patient of X-linked recessive disorder or autosomal recessive disorder, which is xeroderma pigmentosa. Here the reparative mechanisms are defective. So whenever the patient is exposed to sunlight, he develops photosensitivity, skin cancers, etc. Next question. Tell me, what is the diagnosis here? Very nice. This is a patient of ataxia telangiectasia. It's a patient of ataxia telangiectasia. You can see that there is mucosal telangiectasia, and in these patients the first feature is progressive cerebellar degeneration giving rise to ataxia. This is also a defective DNA repair disorder. Okay. Next. The next question. A girl child with verrucous lesion at an age of 2 weeks later on develops the linear bands of hyperkeratotic papules nodules followed by word pigmentation. Her mother reports history of in utero child death, hyperpigmented atrophic lesion. What is the diagnosis? What is the diagnosis? Anyone? What is the diagnosis here? This is a patient of incontinentia pigmenti. It is an X-linked dominant disorder where you have defect in NEMO gene. Now, how will the patient present? On the lines of Blaschko's, we have vesicles in stage 1, then verrucous lesion in stage 2, hyperpigmentation and hypopigmentation. So that is the sequence. Vesicles, verrucous lesions, hyperpigmentations or hypopigmentations. Next, what is the answer? Very nice. Now the question asks 21. A 21-year-old man with multiple small hypopigmented lesions on the upper chest, back. The macules were circular and they are arranged around the follicles. They are confluent to discrete to confluent with fine scaling, and there is a history of recurrence. Can you tell me what is the diagnosis? You are right. The answer is option number 1. What is the diagnosis? It is pityriasis. It is pityriasis versicolor. It is pityriasis versicolor. It is pityriasis versicolor. And for pityriasis versicolor, we do a KOH mount. Can you tell me what is the finding in KOH mount? What do you see when you do a KOH mount in these patients? What will you see when you do a KOH mount in these patients? When you do a KOH mount in these patients, you will see what is known as spaghetti and meatball appearance. Spaghetti and meatball appearance. Spaghetti and meatball appearance. Next. Now what is the answer? The image is something which is like little specific. What is the diagnosis when patient of OCD picks a real or imagined acne on the face? This is a patient of acne excori. And please remember, along with anti-acne medicines, you need behavioral modification therapy. behavioral modification therapy. Along with this, you need a behavioral modification therapy. Clear? Clear? Next, why we need behavioral modification therapy? Because if we will not ask the patient, again when the lesion develops, patient will start scratching the lesion, and ultimately the acne excoriae lesions becomes more permanent. Patient will have scarring, patient will have pigmentation which is more frequent. Okay? Now 25-year-old patient with hair loss presented to your clinic, history of thyroid disorders since 6 months. What is your clinical diagnosis? What is your clinical diagnosis? Now whenever you see the acute illness or a chronic illness, the hair fall start after some time, and that type of hair loss is known as telogen effluvium. For example, post-COVID, post-typhoid, malaria, dengue. So any of the acute illness, even after delivery, when a pregnant patient delivers, during pregnancy nothing happens, but 2 to 3 months after delivery, patient develops hair fall, and all these type of hair fall is known as telogen effluvium. What is anagen effluvium? What is anagen effluvium? This is when you take cancer chemotherapy. Cancer chemotherapy induced is a very classical anagen effluvium. Next, what is the answer? Yes, even post exam, that is true, positive vibe, absolutely right. Like after the NEET PG, maybe a few fraction of you all can develop, because exam is a stressful situation, and if you do not take or do not eat properly during the exam time, you can develop all these features. Very true. Next, what is the answer? Remember that you never give steroids. You never prescribe steroids in a patient of acne, in a patient of psoriasis. These are few conditions where you never give steroids. But sometimes psoriatic patient receives the steroid from some local doctors who are non-dermatologists, non-qualified, and in that case the well-defined nature will become ill-defined, and the plaque will increase in size, involving more than 90% of the body surface area. This is known as erythrodermic. Please remember, students, the question clearly mentioned that after stopping the treatment, the disease have worsened up from chronic plaque. After stopping the treatment, the disease went into erythrodermic, and that is why it cannot be a drug reaction. Drug reaction occurs when the patient is on the drug, not on stopping the drug. So that is a very important difference. So this is a case of erythrodermic psoriasis. Erythrodermic psoriasis. "30-year-old female with lacy lesions on the oral cavity, genitals, proximal nail fold have extended onto the nail bed, what is the most likely diagnosis? What is the most likely diagnosis? What is the most likely diagnosis? Anyone? Presence of white lacy pressure in the oral cavity. This is reticulate oral LP. And what are these? These are dorsal pterygium. The extension of the nail fold over the nail plate. Both of them are the features of lichen planus. Treatment of erythrodermic psoriasis is methotrexate. Treatment of erythrodermic psoriasis is methotrexate. Here you have to give methotrexate as the treatment of choice. Next, anyone? Anyone? 53-year-old lady with medical presented to medical assessment unit with a flu-like illness and myalgia. In the last few days, she noticed a rash across her back. She had no other symptom. On examination, she looked unwell. There is a rash across her back with grade 4 weakness proximally. Muscle enzymes enlarged. What is the diagnosis? Please remember, this is a very classical description of dermatomyositis. In dermatomyositis, you have features of proximal muscle weakness, and what else you have? You have features of skin involvement in the form of rash over the face, which is known as heliotrope rash. Then you can have thickening of the knuckles known as Gauthron's papules and plaque. Okay, so please remember that is a feature of dermatomyositis. Next question. Yes, even mechanic hands, holster sign, ragged cuticles, they are all the features of dermatomyositis. A 45-year-old male with multiple hypoesthesia, elevated margins on the trunk, ulnar and lateral popliteal nerves on the right side are enlarged. What is the diagnosis? What is the diagnosis? The answer to this question is option number 4. Now, how to solve these type of questions? Let us discuss some tricks. Whenever you get a question from leprosy, always look for the number of lesions. Whether you have few lesions or whether you have multiple lesions. Whether you have few lesions or multiple lesions. Few lesions means either TT or BT. BT, they will give you a hint like satellite lesion. In multiple, it could be BB, BL, LL. In BL, the lesions are present asymmetrically. While in BL and LL, they are bilaterally symmetrically distributed. Bilateral symmetrical. Now, how to differentiate between BL from LL? In BL, there is loss of sensation over the plaques. But for LL, there is no such loss of sensation seen. No such loss of sensation seen. Clear? So that is how you differentiate. The question clearly mentions that it is multiple, present, bilaterally symmetrical, but you see hyperesthesia over the patch. So this becomes borderline lepromatous leprosy. Borderline lepromatous leprosy. I hope everybody have understood. Next question. Check the MDT schedule in adult leprosy and mark the correct option. Check the MDT schedule in adult leprosy and mark the correct option. Very nice. Now checking the MDT schedule in adult leprosy and mark the correct option. Please remember, in an adult patient you give 60 mg once in a month supervised, that is true. Clofazamine 300 mg once in a month supervised, true. Depson is 100 mg. Depson is 100 mg, not 50 mg. So that is false. And clofazamine is 50 mg, that is true. Correct answer is A, B and A, B and D. A, B, D is the correct answer. For childhood leprosy, the dose of rifampicin becomes 450 mg once in a month supervised. Clofazamine becomes 150 mg once in a month supervised. Depson is 50 mg and clofazamine is 50 mg alternate day. So that is the difference between an adult or a child leprosy. Adult or a child leprosy. That is the difference between adult or a child leprosy. Clear? Moving to the next one. Moving to the next question. Isthmione. What is isthmione? Isthmione. Very nice, all of you. The word isthmione is used for genital elephantiasis, where there is swelling, thickening or deformity of female genitals, and it is a very classical feature of lymphogranuloma venereum. Lymphogranuloma venereum. Lymphogranuloma venereum. Next question. What is the answer? A 25-year-old commercial sex workers come to the venereal department with complaints of recurrent skin lesion. Complaints of recurrent skin lesions. The lesions are multiple grouped ulcers which are painful. They have a tender lymph node. There is also a history of drug allergy to penicillin. Which kit you will give to treat the patient? Can you tell me what is the diagnosis here? Painful ulcer plus painful lymph node plus history of recurrence. So this is a very important history which gives you a diagnosis of herpes genitalis. It gives you the diagnosis of herpes genitalis, and please remember the correct answer of this question is, for herpes we give red kit. Avinash, I'll try to make a short video to remember, or how to remember the kit of STD. So I would request all of you to kindly follow me so that you will stay updated. Before the exam, I'll try to post all the important small short subjects, small short topics which is important for your exams. So this is the kit, and the mnemonic to remember the kit is, you can just write it down: grey girl, wearing bracelet, reading yellow book. So grey girl wearing bracelet, reading yellow book. That is the mnemonic. Next, so I will definitely take a short session on STD kit. That is important, I know, for especially for INI-CT exams. It is very important, and that is why I want every one of you preparing for the exam to know STD kits at least. What is the answer here? Partner kit is not required for treating dash. Partner treatment is not necessary when treating with which syndrome management kit? The answer is option number. There are 3 STDs or 3 infections where you do not need partner treatment: bacterial vaginosis, herpes genitalis, and candidiasis. For all 3 of them you do not need any partner treatment. For all 3 of them you do not require any partner treatment. Okay? So the correct answer is option number 3. Now next, what is the answer? What will be the answer? Very nice, Prince, Sachin, Nick, Akshata, Abhishek, positive, Sai, Kishore, Shehtas. There is a short incubation period of burning micturition. When you examine the discharge, you can see gram-negative diplococci both within and outside the polymorph. Very classical description of gonococcal urethritis. How to differentiate gonococcal from non-gonococcal? Very important question. How to differentiate gonococcal urethritis from a non-gonococcal urethritis? Gonococcal or non-gonococcal? First is the incubation period. For gonococcal, it is always less than a week. For non-gonococcal, is more than equals to 2 weeks. In gonococcal, you see profuse discharge per urethra. You see profuse discharge per urethra, but for non-gonococcal, you see scanty discharge. Now remember that this is in majority of the cases. It doesn't mean that profuse is always gonococcal and non-profuse or scanty is always non-gonococcal. No. The other clue is when you do a gram stain, you will see more than equals to 5 polymorphonuclear cells with gram-negative diplococci. For non-gonococcal, when you do the gram stain, you will see more than equals to 5 polymorphonuclear cell with no organism present. Clear all of you? No organism present. Can I get a quick thumbs up from everyone if you have understood? So short incubation period, presence of gram-negative infection, both of them give you a clue that you are dealing with a patient of gonococcal urethritis. Now the next question is on your screen. Next question is on your screen. Men presented to STD clinic with urethritis, discharge. Gram stain shows numerous pus cell but no microorganism. Culture is negative on routine laboratory. What is the most likely agent? What is the most likely agent? Very nice. Hulk, Nick, Avinash, Prince, Sachin, Yogit, positive vibe, Shehbaz. A man who came to STD clinic with urethritis, urethral discharge, numerous pus cells but no microorganism, and the culture is very difficult to perform. This is a description of non-gonococcal infection secondary to chlamydia. We have many causes of non-gonococcal, but chlamydia trachomatis is one of the most common cause of non-gonococcal urethritis. Most common cause of non-gonococcal urethritis. Next. What is the answer? Very nice, Prince. Kishore. Patient develops arthritis, conjunctivitis, urethritis 3 weeks after sexual exposure. What will be the diagnosis? What will be the diagnosis? The answer of this question is triad of arthritis, conjunctivitis, urethritis is reiters, and it is usually seen secondary to chlamydial infection. You can also see it secondary to gastrointestinal diseases like Salmonella, Shigella gastroenteritis, but with respect to STD, it is mainly because of chlamydia. So 2 to 3 weeks after chlamydial infection, you see the development of the triad of arthritis, urethritis and conjunctivitis. Next question. What is the answer? A 25-year-old male with thickened palmar lesions with pus leaking out, succinate balanitis, a red eye, he is suffering from. He is suffering from. He is suffering from. Great. This is again a patient of Rita's disease. Please remember, in the patients of Rita's disease, they develop palmar lesions, which is known as keratoderma blanoregica. Keratoderma blanoregica. And there is presence of circular ulcers on the genitals, which is known as succinate balanitis. So the answer to this question is option number 2. Next. Can you tell me the answer? The syndromic management of urethral discharge includes what? Syndromic management of urethral discharge includes what? The syndromic management of urethral discharge includes the treatment of both gonococcal and non-gonococcal. Always remember that you never treat a single disease. You never treat only one organism, because majority of the cases have a mixed infection. And when there is mixed infection, and if you only treat one, after a lag period the patient start developing the features of other. So it is always important to treat both gonococcal and non-gonococcal. And can anybody tell me what is the treatment? What do you give? What is the management? For gonococcal you give cefixime 400 mg stat dose, and for chlamydia you give azithromycin 1 gram. Chlamydia azithromycin 1 gram. Next. Now before going to that question, let us do this one. I'll tell you later that what are the resistant structures. Which of the following is the most recommended diagnostic test of chlamydia? Which of the following is the only recommended diagnostic test for chlamydia? Nucleic acid amplification test, ELISA, microscopy. The answer is option number 2. Nucleic acid amplification test. You cannot demonstrate chlamydia on the normal culture or routine culture media. You need to do some amplification test to look for the patient's chlamydia status, and that is why we do nucleic acid amplification test. Clear? There is no culture, there is no routine microscopy which you do, but nucleic acid amplification can give you an idea of chlamydia infection. Woman was treated with antibiotic for 2 weeks for streptococcal pharyngitis. 2 weeks later she complains of genital burning. White curdy vaginal discharge. What is the diagnosis? Anyone? Very nice. Vikram, Kishore, Muttu, Nix, Satyam. The correct answer of this question is option number 4. Please remember, what are the predisposing features for development of candida? What are the predisposing features for development of candida? Number 1 is you see them in the patients who have immunosuppression. Can be local immunosuppression, can be generalized immunosuppression. In the patient, those who have diabetes mellitus. In those who have diabetes mellitus. And what else? It is also seen in those where you have prolonged antibiotic use. When you take prolonged antibiotic, what happens? The normal commensals also die. And when the normal commensal die, the problem starts. The pathologic organisms which are anyway present in these areas like candida, they start proliferating. And this candidal proliferation will then cause burning, itching as well as white curdy discharge. White curdy discharge. Moving to the next part. Colpitis macularis is seen in which STD? Colpitis macularis is seen in which STD? Colpitis macularis occurs in which STD? Colpitis macularis is seen in which STD? Remember that colpitis macularis, what is colpitis? It means inflammation of cervix which presents with red macules, and it is nothing but another name for strawberry cervix seen in the patients of trichomoniasis. It is another name of strawberry cervix seen in the patients of trichomoniasis. Moving to the next question. Moving to the next question. Jerish eczema reaction. A patient diagnosed with secondary syphilis was given an injection benzathine penicillin, and a few hours later he developed fever, headache, exacerbation of the cutaneous lesion. What is the diagnosis? So if a patient develops sudden exacerbation of the existing lesion within few hours of getting benzathine penicillin, it is a very classical Jerish eczema reaction. Now this occurs in the patients with high treponemas, so early infectious stages like primary or secondary. And the reason behind this is because of sudden killing, of treponemas. When there is sudden killing of treponemas, it generates an inflammatory response giving rise to Jerish eczema reaction. That's an old PGI type of question, so I want more than one correct options here. You have more than one correct option, so can you tell me the answer? What all lesions are seen in the patients of secondary syphilis? So let me make, now try to answer it here. Tell me which is correct, A, B, C or D. Which is the correct answer? A, B, C or D? A, B, C or D? The correct answer is option number B. Gumma is a feature of tertiary syphilis. Condyloma lata, skin rash and alopecia, they are the feature of secondary. And canker is a feature of primary. Canker is a feature of primary. So option number 2 is correct. 2, 3 and 4. 2, 3 and 4. Next question. Which of the following does not cause urethritis in males? Which of the following does not cause urethritis in male? Which of the following does not causes urethritis in male? I think it's an easy question. The answer is Haemophilus ducreyi. Haemophilus ducreyi is known to cause genital ulcer. Haemophilus ducreyi is known to cause genital ulcer. Clear? Anybody has any confusion? I hope I'm audible and visible. Now moving to the next question. This is a classical picture of. Now let me give you some hint that she is a young female there is also associated oral ulcers, and now she complains of multiple painful bullous or erosions on the trunk. So these are the few hints which I have given, and now I think it is very easy for the patient for you to solve the question. Oral lesions, bullous erosions mainly on the upper trunk, very classical feature of pemphigus. So this is one of our own patient who presented with some vesicles. You can see the vesicles here, and when we started our own treatment, the lesion started to heal. Next, what is the answer? What is the answer? False about this condition. False about this condition. False about this condition. Now the lesions are itchy, pigmented, there is presence of alopecia, and you have stretch marks. What is the diagnosis? Now this is a patient, if you look at the image, this is a patient of lichen planus. Can you see? Flat topped purple papules mainly present on the flexure. So this is one of our own patient who presented with these lesions. This is known as lichen planus. This is known as lichen planus. They are highly itchy. They heal with pigmentation. You see alopecia, but they never present with stretch marks. All of the following statements are correct except option number 4. In lichen planus, patients will never scratch your skin like this. They will rub the skin, and when you rub the skin, you do not develop stretch marks. So that is the difference. Next question. Next question. Next question. Clear? What is the correct answer? True association. Can you tell me what is the diagnosis? What is the diagnosis? If you can tell me the diagnosis, the answer becomes very easy. For that you need to look at the image. Look at the image. This is one of our own patient. She presented to us with complaints of photosensitivity. When we examined her, we could see that there are some freckling which is present on the exposed part with scarring. We made a diagnosis of xeroderma pigmentosa. And please remember, it is a DNA repair defect presenting with nucleotide excision repair defect. Xeroderma pigmentosa. Xeroderma pigmentosa. Xeroderma pigmentosa. Next. Correct match. Correct match. Cafe au lait macule appears little late. Axillary freckling is pathognomic. Neurofibromatosis 1, it is because of chromosome number 22. And neurofibromas have more than 6. When they are present in more than 6, then it becomes diagnostic. So you have to tell me the correct match, and the only correct match is option number 2. Cafe au lait macule appears first. It appears first. Cafe au lait macule appears first. NF1 is chromosome number 17 defect. Chromosome number 17 defect, and neurofibroma should be more than equals to 2 for making the diagnosis. It should not be more than 6, more than equals to 2. More than 6 is for cafe au lait macule. And this is our own patient. Can you see there are so many lesions? This is our back. And if you look at this hand, this is a plexiform neurofibroma, large lesion present on the hand. Plexiform neurofibroma. Plexiform neurofibroma. Next. Plexiform neurofibroma. Plexiform neurofibroma. Plexiform neurofibroma. Now here we have an old patient with a very characteristic lesion. Duration is more than 2 months, 2 years. Diagnosis. So we recently got a question in NEET PG 2022. In NEET PG 2022 we got a question on the same topic. The answer to this question is option number 1, basal cell carcinoma. Basal cell carcinoma. The answer to our question is basal cell carcinoma. Next. A lady with the pigmentation on the cheek, photosensitivity. Pigmentation on the cheek. It is only pigmentation. So this is melasma. The melasma patients have photosensitivity and they develop pigmentation. But here they develop a rash. That is the difference. Next. What are these scales called as? Fish-like scales. Fish-like scales. What are these scales known as? Identified. These are ichthyotic scale. Please remember in INI-CT 2022 we had a question on these scales. pityriasis rosea colorate scale, psoriasis mycacia scales, pityriasis lichenoides atrophica PLA or PLC with very characteristic mica-like scales. Pityriasis lichenoides atrophica. Any treatment for ichthyrotic scale, simple moisturizer. Clear? Next, what is the answer? A patient with soreness in the mouth, rash in the hand and the feet, and the image given below, what will be the causative organism? What is the causative organism, or what is the answer? Very nice. The correct answer of this question is option number 1. It is very frequently seen nowadays, and this is a very classical example of hand, foot and mouth disease. You develop the triangular or angulated vesicles on the hand, around the mouth, on the foot and even on the buttock. Very classical hand, foot, mouth disease, and it occurs secondary to Coxsackie A16 virus. Next, it occurs very classically secondary to Coxsackie A16. So 15-year-old boy has an intense itching since 1 week. On examination, there is large circular lesions on the back. The likely diagnosis is, what is the likely diagnosis? What is the likely diagnosis? This is a patient of tinea corporis. Tinea is a dermatophytic infection. And it presents classically as annular lesions with activity at periphery, annular lesion with activity at periphery and clearing at the center. Okay? You can see anywhere, see, corporis is not only the anterior part, anywhere on the body. If you see an annular lesion, this is a patient of tinea corporis, dermatophyte. Now look at the image. This I think I've shown in the past as well. A plaque with atrophy of the center. Very nice. The atrophy, whenever you see atrophy, the diagnosis becomes cutaneous tuberculosis. It is a very classical lupus vulgaris, and you have to treat it according to or in the lines of M tuberculosis. You give 2 months of intensive phase and 4 months of continuation phase. 4 drugs in intensive HRZE and 3 months HRE, 3 drugs in the continuation phase. 18-year-old male with following rash, again a very characteristic feature. Look at this image. Can you see this thickening on the knuckles? The hands are mechanic hands, and if you see, there is a slight erythema around the eyes. So the first image is Gotrin's papule, then mechanic hand, and then heliotrope rash, all features of dermatomyositis. Along with that, there was a history that this patient was not able to get up from the sitting position. So proximal muscle weakness, proximal muscle weakness, proximal muscle weakness, proximal muscle weakness. Proximal muscle weakness. A male patient presented with a flat lesion. Look at this image. There are a flat hyperpigmented lesions which are present on the forehead, which is rapidly progressing. What will be the diagnosis? What will be the diagnosis? The answer is lichen planus. A male patient with a flat lesions on the face which is increasing gradually, the diagnosis becomes that of lichen planus. Next. Next. So varicose will be also very similar. The verrucous lesion will be more of skin colored lesions. A child with history of diarrhea following skin manifestation. Muthu, please remember that verruca plana will be hyperpigmented to skin colored. They are usually asymptomatic, and lichen planus has a very characteristic purple appearance. They can be grouped, they can be present anywhere on the body. Most frequently they are present on the flexures along with that of face. This is a patient with zinc deficiency, which is acrodermatitis entropathica. Acrodermatitis entropathica. What are the features of acrodermatitis entropathica? Very classical feature is dermatitis, alopecia and diarrhea. Very nice. Dermatitis, alopecia and diarrhea. 20-year-old boy with this circular areas of complete hair loss. What is the most expected nail finding? What is the answer? What will be the answer? Very nice. The answer to this question is geometric pitting or uniform pitting. Geometric pitting or uniform pitting. Next. Diagnosis of a man with diffuse hair loss involving the crown, frontal scalp without maintaining of a frontal hairline. Very nice. This is a patient with male pattern hair loss or androgenic alopecia. Male pattern hair loss or androgenic alopecia. Next. So for a child, this is a child. You were called in the emergency department for a child who developed skin exfoliation. Mother gave a history of fever, irritability. Vitals are stable. What could be the diagnosis? What is the diagnosis? Great, very nice. The answer is staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome. Now, whenever patient has any illness, which could be sore throat, ear infection, and following which there is a tenderness followed by skin peeling, like this, very classical. This is a patient of staphylococcal scalded skin syndrome. It occurs because of release of a toxin from the staphylococcus, which is known as exfoliative toxin. This toxin goes and inhibit desmoglein 1, causing exfoliation of the skin. Now this question, a 10-year-old boy with painful bogey swelling of the scalp, multiple discharging sinuses, easily pluckability of hair, lymph node enlargement. Which of the following would be the most helpful diagnosis for this particular patient? Impetigo contagiosa, see, Shishir, Impetigo contagiosa is more of crust. Impetigo contagiosa is the name given to non-bullous impetigo. So you will see a lot of crusting in them. You will see a lot of crusting in them. Okay. Yellow colored, honey colored crust. Can you tell me diagnosis here? What is the correct answer? So the diagnosis here is Kirion, which is a example of inflammatory tenic hepatitis, and you do a KH mount to look for the presence of fungal hyphae. Next, a male patient develops multiple red oval macule after taking metronidazole. History of similar lesion at the same site 6 months back. What is your diagnosis? What is your diagnosis? What is your diagnosis? Very nice. It is fixed drug eruption. A very characteristic purplish appearance with erythematous border. Whenever patient takes the culprit drug, the lesion occurs on the same site, and once the patient stops taking drug, it heals with hyperpigmentation. Fixed drug eruption. Fixed drug eruption. Next, female with hyperpigmented patch, hairs on the lower body since birth. The diagnosis is female had hyperpigmented patch with hair on her lower body. What will be the diagnosis? What will be your diagnosis? Great, very nice. The answer of this question is congenital melanocytic nevus. I have shown this image in the past. Can you see? Pigmented area with hypertrichosis. It's a giant congenital melanocytic nevus, and for these patients, they always need to keep a check on them, because these lesions, they are pre-malignant. They can convert into malignant melanoma. So they should keep a check on them whether they are increasing suddenly like that. Next question. Eczema which can lead to these conditions are all except. Eczema which can lead to this condition is, this is a very classical example of exfoliative dermatitis. Exfoliative dermatitis. And please remember, other than nummular eczema, all three of them can reach to this stage. All three of them can reach to this stage. Next, let us move it little down. I hope you can see the image. Let me show it again. The answer to this question is tubercular lymph node or scrophulloderma. Tubercular lymph node or scrophulloderma. Next, alcoholic with history of delirium, diarrhea. Alcoholic with history of delirium and diarrhea. Alcoholics with history of delirium and diarrhea. Niacin deficiency, zinc deficiency, selenium deficiency or riboflavin deficiency. Alcoholics with history of diarrhea and delirium. The correct answer is option number 1. This is a very classical image of pellagra. We have already done a question in the morning or in the beginning of the today's session. So this is just another question in the same topic. Next, Kaposi viriliform eruption is varicella-like grooved vesicles in a Kaposi sarcoma patient, infection with herpes in a patient with atopic dermatitis, infection with HHV8 resulting in cutaneous exanthem distributed centripetally. What is the correct answer? What is the correct answer? Great. The answer is option number 2. This is nothing but another name given to eczema herpeticum. This is another name given to eczema herpeticum. Eczema herpeticum. Here you have grouped vesicles on the angle of the mouth or on the genitals. But because of underlying atopic dermatitis, you even get them spread over the different areas like eczematous areas. And that is why it is known as eczema herpeticum. That is why it is called as eczema herpeticum. Physical urticaria, I think this is very easy question, image based. Vineet, Veena, Rao, Chitra, Nisha, Akshata, Sanjeev. Very, very easy question. Identify this physical urticaria. This is a patient of dermographism. This is a patient of dermographism. Okay, next. A patient with a rash of more than 30% with hemorrhagic crust on the lips. What is the diagnosis? Can anybody tell me what will be the diagnosis? What will be the diagnosis? The diagnosis will be toxic epidermal necrolysis. Toxic epidermal necrolysis. And please remember, drugs are one of the very important cause for them. Drugs are one of the very important causes for them. Drugs are one of the very important cause for them. Next. A male patient with patchy loss of hair on scalp, eyebrows, beard. He also had history of rapid graying of the hair in a few areas. What is the likely diagnosis? Alopecia areata, anogenic effluvium, tenogenic effluvium, and androgenic alopecia. What is the likely diagnosis? Alopecia areata, anogenic effluvium, telogenic effluvium, and androgenic alopecia. The correct answer here is option number 1. Patchy hair loss and only the pigmented hairs are affected. The white hairs are spared. This is a very important clue. The white hairs are spared but the pigmented hairs are affected. Alopecia areata. What is the answer here? Nevus of Ota, Ito, Mongolian spot, or hypomelanosis of Ito. Hypomelanosis of Ito. Identify this patient's condition. The answer is nevus of Ito. The answer to this question is nevus of Ito. What is nevus of Ito? It is a dermal melanin disease where the melanoblast or the precursors of melanocyte, they get prematurely arrested in the dermis and they start proliferating there. The reason why they appear blue is because they are present in the dermis. Next question. Nevus of Ito is at the back. Nevus of Ito is at the back. This is nevus of Ota. What is the first line treatment for acne comedones? First line treatment for acne comedones. First line treatment for acne comedones. First line treatment for acne comedones, it is always topical retinoids. We need to give keratolytic drugs. We need to give keratolytic drugs to take care of these lesions. Identify this patient's condition. There is a verrucous lesions on the genitalia. What is the answer? We have a verrucous lesions on the genital of these patients. Verrucous lesions on the genitals of this patient. What is the diagnosis? Verrucous lesions on the genitals. Identify this. Very nice. This is a patient with condyloma acuminata or genital wart. It is HPV 6 and 11 which causes the genital wart. It is the HPV 6 and 11 which causes the genital wart. Next, HPV 6 and 11 which causes the genital wart. A patient of lepromatous leprosy what is the answer? Very nice. It is the clofazimine which induces the pigmentation. So with this we are done with today's session. I hope everybody have enjoyed. We have one more session at 5. So I would be recommending all of you that please join us. There is another session which is scheduled for 5 p.m. today. It would be a 1-hour session as well. It would be a 2-hour session, I'm sorry. It will be a 2-hour session. So requesting all my students to kindly be the part of that session also.